talk a little bit about trauma-informed care and really shaping our HIV practice around this. So trauma is an event experienced by a person that leaves a long-term negative effect. It can be experienced by an individual or an entire population, and often these are intersectional. Trauma may be due to many things, including adverse childhood experiences, race, ethnicity, sexual orientation, mental health comorbidities, and homelessness. People with HIV are 20 times more likely to have experienced trauma than the general population. And beyond the many sources of trauma, there are things specific to HIV that contribute. HIV care itself, such as invasive procedures, maybe the way they're treated by staff, systemic abuse and insensitivity, the cost of care and navigating benefits, all the obstacles that there can be to obtaining care, hypervigilance around labs and diet and other health issues, the need to take medications for life, and sometimes this entails taking many pills, diagnosis anniversary dates, and the role of stigma really cannot be overstated. As providers and people who work with people who have HIV, we really need to lead the change through our words. Our language is so important when it comes to our interaction with clients and also how we portray our clients to other people. So it's important to use clinically accurate and medically appropriate language when talking with and documenting about people with HIV. Stigma and stereotypes faced by people with HIV can impede solutions that work to end homelessness. Using person-first language can shift understanding of structural and societal causes around homelessness and many other issues. First-person language can reduce stigma, increase patient willingness to seek treatment, reduce negative provider perceptions of people with HIV, and improve care. For example, rather than saying a homeless person, a person experiencing homelessness is preferred. When talking about somebody who uses substances, a person who uses drugs rather than an addict, that word can be so stigmatizing. A person with HIV, instead of saying HIV infected, there are many ways to talk about acquiring HIV that doesn't need to use the word infected. Along those lines, a person with mental illness rather than somebody who's mentally ill, or that word that we should always avoid, crazy. So we'll get into SAMHSA's definition of trauma-informed care. First, we'll talk about their 3 E's of trauma. So trauma results from an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, and emotional and spiritual well-being. And then this leads into the 6 key principles of trauma-informed care: establishing a safe environment, both physical and psychological, trustworthiness and transparency, really building trust with the person you're working with, peer support, and being around people with lived experience of both trauma and HIV can be very helpful. Collaboration, understanding, partnering, and recognizing levels of power differences, calling out those things in the beginning of an encounter. Empowering clients, asking open-ended questions, letting their voice be heard, and listening in return, giving choice in their healthcare and other issues. And then having a good sense of cultural, historical, and gender issues will help as well. Putting all that together, trauma-informed care is a conceptual framework that considers a patient's previous experiences with trauma and informs providers' interactions with patients. So in regards to HIV, there are many benefits to trauma-informed care. It can prevent staff burnout by encouraging clients to promote self-care and providing ongoing training and peer support. It can reduce substance use and other high-risk behaviors. It can help reduce mental health comorbidities. It can really strengthen the patient-provider relationship. It can improve ART adherence and increase care engagement or retention in care. The graph on the right demonstrates a study that just shows the integration of trauma-informed care into a clinic and the reductions in patients who are lost to follow-up. And you can see the reductions over time as trauma-informed care was integrated into this clinic. We'll talk about a few strategies to incorporate trauma-informed care. So some of the principles that we consider are physical and emotional, safety, collaboration, trustworthiness, empowerment, giving somebody a voice and choice, peer support, and then having a good understanding of cultural and historical issues. These were discussed a few slides ago. And then how you can approach really carrying out these principles would be to be consistent in how you approach clients, ensure privacy, provide expectations about what is going to happen up front, and explanations as to why things are going to go the way they are. Forming a relationship with the patient will really encourage healing, giving opportunity for shared decision-making that can really level the field, especially with power differentials. Involve everyone in the clinic or organization in a trauma-informed care approach. Make sure that roles are clearly delineated. Use informed consent and standard grievance processes. Build and maintain trust among staff, patients, and families. We can give patients a voice and choice by understanding patients' coping mechanisms, increasing individual control and autonomy, and really framing a client's experiences as survivorship rather than victimization. We need to recognize the utility of peer support and mutual self-help in building trust, collaboration, and safety. And then lastly, when considering historical, cultural, and gender issues, making sure we have a good understanding of what it means to provide gender-affirming care, recognizing and addressing historical trauma, and then really moving past any cultural stereotypes and biases. I really like to think of this as shifting the question from what's wrong with you to what happened to you. This changes the focus and allows for trauma-informed care to take hold. So there are many strategies to incorporate and implement trauma-informed care, and it really depends upon the bandwidth of your organization, although many of these are actually pretty simple to incorporate. So recognition and awareness. Recognize potential impact of trauma on retention and care. Training, obtaining foundational knowledge. All staff should be trained and have a fundamental knowledge of trauma-informed care. Agency readiness. Ensure the staff are mentally and physically ready to incorporate trauma-informed care. Process and infrastructure. Policy and practice must support trauma-informed care at all levels. Gather information and identify opportunities. Conduct a trauma-informed assessment to identify opportunities and measure practices. Prioritize and create a work plan. Identify processes for prioritizing opportunities that works for your clinic. How can this be embedded in clinic processes? Implement and monitor. Conduct evaluations as changes are being implemented. This would really allow to make changes as needed as any processes are being introduced. And lastly, celebrate and maintain. Maintaining commitment and momentum around trauma-informed care will promote longevity of these practices. Below are just a few resources for training programs around trauma-informed care. You can also check your local resources or state-run websites for additional resources. At a clinic level, I think many of the things we talked about can be critical. I think first, it's important to educate staff about trauma-informed care and make sure everybody has a clear understanding of what it means. And then thinking of implementing trauma-informed care, it should really be something that is practiced by everybody and driven by the way that we interact with staff and other clients. I think very often it's easy to question patients' motivation and to be quick to judge, like, why didn't they show? They're probably doing this. This person can be so difficult. Really shifting that conversation to why is this person not here? It could be they experiencing homelessness. Is something going on in their life that is, promoting stigma and shame. So just thinking about what might be happening in a client's life that is driving outcomes, whether good or poor outcomes.